Good afternoon, everybody, and thanks for attending our webinar this afternoon. Today we are talking about the Stage 2 menu measures and also how to best prepare for GE Centricity CPS12 and or the 9.8 upgrade. I'm Jen Monahan with Health One Technologies, and presenting along with me is Tanya Martin. Just a few quick things that just reminders for those of you that have not attended our webinars in the past. We will hold all the questions until the end of the webinar. There should be a questions window located in your GoToWebinar session that you can type your question in. And at the end of the webinar, we'll actually address all of those. The slides and the webinar itself will be available, and we will send a link out to everybody for that within a few days after our webinar actually completes. Okay, so today we're going to talk about, first off, we're going to go through just the Stage 2 menu measures, what they mean to you, what has to be accomplished to actually get to meeting those menu measures. And then we're going to talk just specifically about preparing for, and I did put CPS12 here, but I guess it's CPS12 and 9.8, depending on what your platform is. We kind of broke this down into operational planning, education and planning, application planning, customizing your clinical content, and system setup. So we will kind of review all of that more towards the end of the webinar. The first part of the webinar will be about Stage 2 measures. I'm going to go ahead and turn this over to Tanya Martin, who is going to begin our discussion with the menu measures, and I will pick up from there about CPS12 and 9.8. Tanya, go ahead.
Good afternoon, everybody. We're going to review first the 6 menu measure options for Stage 2, the first being the electronic syndromic surveillance data to the public health agencies. The second one is the to record electronic notes in the patient's record. The third is the image results accessible through your CCHIT certified EHR. The fourth is to record patient family history. And the fifth is to report cancer cases to public health agencies. The sixth is to report specific cases to a specialized registry. So for the menu measures for Stage 2, the requirement is to meet 3 out of 6. There is an exclusion to this, or a caveat to it, we'll say, that while there are exclusions provided for some of the menu measures, you cannot select a menu measure and claim an exclusion if there are other menu measures that you could report on. So you can't just go in and claim an exclusion for a menu measure, yet you're able to meet 4 of the other ones or 3 of the other menu measures. It's kind of an all or nothing. So the first menu measure option is the syndromic surveillance data submission, and the requirement is to submit ongoing successful submission of syndromic surveillance data from your certified EHR, and it has to be 2014 certified EHR, to a public health agency for the entire reporting period. And if you've attended our previous seminars, you know that for 2014, everybody's reporting period is 90 days. So the exclusion to this is that an EP that is not in a category of providers that collects ambulatory syndromic surveillance information on their patients, they would be able to claim an exclusion. If the EP operates in a jurisdiction where a public health agency isn't capable of receiving that information, if the EP operates in an area where the public health agency provides information, does not provide information on a timely ability to receive that information, that syndromic surveillance information, or if the EP operates in a jurisdiction where no public health agency is capable of accepting that data. The second menu option is to record the electronic notes into the patient's record. So quite obvious. You're going to record electronic notes in the patient's record. At least one progress note is either created, edited, or signed by an EP for more than 30% of your unique patients with at least one office visit during the reporting period. I know there's a lot of if, then, they in the measure, but quite simply, if you are recording your patient's notes into your EMR, this would be an easy one to meet. The text of that note must be searchable, so it must contain information that, text that is searchable. So in GE's case, it needs to be connected to an OBS term. There are no exclusions for this. However, there are some notes that you may want to take note of. Your EP may author, edit, or provide an e-signature for the note, and that would be considered for the measure, so you'd actually meet the measure using that workflow. The EP or an authorized provider may be the author of the note. They may edit it, sign it in any manner except for dictation, including dictation, as long as the end result is text searchable. So in this case, with this measure, the capability to have a text searchable document is key. Non-text searchable notes obviously do not qualify for this, and drawings and other types of content can be included with the note, but again, it has to be text searchable. So menu 3 is the imaging results, and the imaging results consisting of the image itself and any explanation or accompanying information need to be accessible through the EMR. So the requirement is that more than 10% of all tests whose result is one or more images ordered by the EP within that reporting period are accessible through the EMR. The exclusion is any provider who orders less than 100 tests or does not have access to electronic imaging results at the start of the reporting period. That's important. The exclusion is at the start of the reporting period. So if we look at what the definition of the measure is, that word accessible meaning that in the EMR, the image and any of the accompanying information are available. It does not have to be through that technology, through your EMR technology. It can be through another piece of technology, but the link to the image and any of the accompanying information needs to be available. So the images and the imaging results that are scanned into the EMR also may be counted in the numerator for this measure. So there are different options to how you can achieve this menu measure. The fourth menu measure is family history. So to record patient family history, health history as structured data, the measure requirement is 20% of all of the unique patients seen by the EP during the reporting period have that structured data entry for more than for one or more of the first-degree relatives, and we'll get into what a first-degree relative is down the bottom, or what they term as a first-degree relative. The exclusion for this is any EP who has no office visits, obviously, during the reporting period. They term a first-degree relative as a parent, an offspring, or a sibling, so pretty straightforward. And some of the notes that you may want to look at is the patients who do not know their family history. It is acceptable for the provider to record unknown into that field. And standards that require the CCHIT certified software to be able to use the SNOMED codes or the HL7 pedigree standard codes is going to actually be available within the next version of GE, and we will get into that later on in the presentation. So now that this menu measure is actually pretty straightforward, and again, if you're using GE and upgrading, it's pretty straightforward and easy to obtain. Menu 5 is identify and report cancer cases. So the capability to identify and report cancer cases to a public health cancer registry except obviously where prohibited and in accordance with the laws and the practices within the state that you're in or nationally. So it depends on what cancer registry you're reporting to. The measure requires ongoing submission of the cancer case information. And the exclusion is that any EP that meets at least one of the following criteria can be excluded from the measure. So if the EP does not diagnose or directly treat a cancer patient, or if the EP operates in a jurisdiction where the public health agency isn't capable of receiving the cancer information, the public health agency provides information timely on capabilities to receive the electronic cancer information, or the public health agency is capable of receiving the information at the beginning of the reporting period. So if any of those fall back onto the public health agency, then you can file for an exclusion on this. The implementation guide for ambulatory cancer registries, the link to that is in the presentation. And again, as Jen stated, we will send this presentation out as soon as we're able to do that a couple of days after our presentation completes. Menu 6 is to identify and report specific cases to specialized registries. So this measure gets a little confusing to people. The capability to identify and report specific cases to a specialized registry other than cancer registries, except where prohibited, and obviously in accordance with the laws that I had mentioned earlier. So the specialized registry, specialized registries would include birth defects registries, chronic disease registries, traumatic injury registries, or any registry that's focused on healthcare-associated infections. Those are all included under specialized registries. So the ongoing submission is the requirement of this data to the registry from your CCHIT certified system. The exclusion, again, pretty much the same exclusion as we saw again above in menu 5, that the EP does not diagnose or treat any disease associated with a specialized registry. The EP operates in a jurisdiction where there are no specialized registries sponsored by a PHA, and the capability of receiving electronic information is not available at the beginning of the reporting period, or that the PHA provides information on a timely manner to the specialized registry, or the last piece is if there is a capability of receiving electronic cases by the CCHIT certified software at the beginning of the reporting period. I will turn this over to Jen.
Sorry, Tanya, I think I cut you off there. So thank you for reviewing the menu measures with us. And as we have done in previous webinars, we've reviewed the core measures, the menu measures, and all of this, while we're preparing for it, is sort of on hold until we actually get our systems in place to actually implement the processes that we need to put into place. So one of the things that I thought it would be a good opportunity for us to do is, while we don't know everything there is to know about the CPS12 or 9.8 systems, to spend some time talking about what we can do to prepare for them while we're waiting, basically. I've kind of outlined here what we know to date about the updated software that's coming out. So we know that GE has officially achieved their ONC certification for 2014, and that's both for CPS12 and EMR 9.8. They announced that sometime in early December, that they were finalized with that component, and now they're just in the testing and the validation process before they provide a general release. They did give us a general release date, or I guess I should say date time frame, somewhere between February 15th and March 31st. And in that time, we will hopefully be able to get full access to the systems and begin actual upgrades and implementation processes. While attending various webinars through GE, speaking to GE folks that are in place, we know that there are several key application changes that they put into place to meet the 2014 criteria, the stage 2 criteria. And along with that, they've introduced several new tables to the database, which anybody that's on the technology side will understand that is definitely an area that I personally am concerned about. And new tables to a database are something that are going to impact potentially various applications throughout the various areas throughout the application. The table changes that they put into place are also going to require us to have some MEL changes, new MEL programming code that will be put into place. So those are things that we know are going to impact us, and we know that we can plan or at least prepare as much as possible for that. We also know that for stage 2, there are various components of this that are going to require us to have third-party applications to meet the measures. And we'll kind of go over that in a little more detail in a couple of slides down when we talk about planning a little bit more. But I do want to make sure everybody is well aware of that particular component, because that is an area that we can potentially start planning now, even though we don't have our programs, our software upgraded. And then lastly, we also know that if we have any delays in either the release, so if for some reason GE is delayed in releasing the application, or if your implementation is delayed for whatever reason, that could potentially cost you not only your meaningful use stage 2 or even your stage 1 dollars, depending on what year you're in, but it can also potentially be associated with the penalties if we are not meeting meaningful use. So this timeline for preparing for both the upgrade and stage 2 is critical for the 2014 year. So what do we not know to date? So we don't know an exact release date. We have some estimates, but we don't have an actual confirmed date at this point. We also don't know the details of how the system navigation is going to change. We have some high-level concepts of what they're adding to the system, forms that they're changing, things that are being released, but we have not seen to date an overall review of the system navigation if things are changing from CPS 11 or earlier versions to CPS 12. The details on the reporting tool have also been sort of limited. We know that there's going to be a mapping tool of some kind, which is going to allow us some flexibility to tell the cloud-based tool on what we're reporting, but we don't know the details of that. And there also has not been a lot released about the IT infrastructure that might need to be put into place to accommodate the update. So what can we do while we're waiting? So the first thing that I'm recommending for folks to do is sort of what I'm calling operational planning. And this is the thing that kind of worries me the most about 2014, are the amount of resources that are needed to get everybody up to speed on not just their upgrades and their software that needs to be put into place, but then ultimately your stage 2 compliance. So I'm telling folks as early as possible, if you need to get quotes from your GE account rep or your VAR or your hosting vendor, whoever that person is, we need to get the quotes in place for the upgrade, and whether that's software that you might need to purchase, things like patient portal, secure messaging, whether you need the clinical gateway for Centricity or the Qvera product, the clinical quality reporting. There's going to be a patient education option available for us in Centricity, but that is a third-party add-on. So any of those quotes that you can potentially get lined up now, get the quotes, get in contact with the person that you need to get the quotes in place. That's just one less step that we have to do when the actual application becomes available. I'm also telling people to get on your IT vendor schedule. We know, again, that this is going to be a very aggressive timeline in 2014, so if you have IT vendors that you work with, I would suggest that you reach out to them and say, we know this software is coming sometime, hopefully by the end of March, so can we get on your schedule in April or May to make sure that we can make this happen? Also, identifying what interfaces you might need. So as we kind of went through the core measures a few weeks ago, we know that we have to have lab results captured discretely into Centricity. So if you don't have an existing lab interface, that may be an area that you need to look at to determine if we need to build that interface, and if it is, to begin contacting the people that you need to make that happen. Same thing with radiology. So again, this is a menu item. We don't have to select it, but if you have a PAC system in place and you don't currently have an interface to that PAC system that provides images, or just in general, a local radiology company that you might work with, and you are thinking that you might select that as one of your menu items, you may want to just look at those interface needs and decide what you need to accomplish in 2014 to make that happen. And then lastly, if you get your quotes, get them approved and signed, because I think we all know that that process itself can sometimes take weeks or months to actually happen. So once everything is signed and ready to go, it should just be a matter of getting on the schedule to get things to actually happen. The next area that we have been getting a lot of questions on, and I am sort of recommending for people to do, is to really look at the financial planning for stage 2 and all the components that need to happen. We are considering a couple of things. So there's the cost associated with the upgrade and reaching meaningful use stage 2. So we know we have to upgrade our software, we have to implement patient portal, we have potential interfaces, there might be hardware requirements. All of those costs are something that we need to understand so that we have a full picture of what that budget looks like. And then on the back end, what potential revenue or penalties do we have if we if we pursue this? So incentive dollars that we know, so we know meaningful use has incentive dollars attached to it. So for some of you that have been reporting since 2011, those dollars are decreasing as you kind of go through the stages. So you want to kind of look at that. I know many of our existing clients are enrolled in PCMH and ACOs, and there's potential additional revenue that you can accomplish there by continuing to move forward with the stages. And then on the back end, which we personally have not talked a lot about in any of our webinars or with our clients, but we are starting to really make people aware of, is that there are penalties associated with not reaching meaningful use. They are supposed to take effect in 2015. Whether or not that will actually occur is, I think, to be determined. But you want to include those when you're doing any analysis of what you're looking at from a budgetary perspective. We have quickly just sort of put together some bullet point spreadsheets that we're working through on some of our clients. And please don't pay attention to the numbers on this screen, because they're just numbers we plugged in to sort of test our formulas. But this is what we're using to help our clients do some budget planning, and basically to understand what our costs are for all of the components, what our incentive monies might be, and also what our reduction might be. And we included, for instance, in our reduction, not just meaningful use, but if you did not do PQRS in 2013, there is a cost for that. If you're not doing e-prescribing, meaningful use, those are all potential impacts on your allowables that come back to you from Medicare. So this tool is something that we are using to sort of help our clients walk through that process and understand the financial impact of what 2014 is going to look like for them. So the next area that I wanted to focus in on is just sort of your own education and planning. I'm encouraging everybody to attend the GE webinars on the application overviews. I'm hoping that you don't find this a duplicate of what they're doing. That's not at all what we are trying to do. We're just trying to put into place the whole picture and not necessarily just the application-specific areas. They do have webinars published on their single sign-on site, so if you have missed their webinars, you can go download them. They are starting to talk more about the application, so I think it's definitely an area that people should attend and review as much as possible just so you can be as well versed as needed on the actual application. Also, begin developing implementation timelines. And I know it seems a little preliminary for that because we don't necessarily have software that we're upgrading, but we know we're going to need to do testing. We know we need to do workflow, training, content development. I did put a red line item in here. If you are coming from 9.5 to CPS12, you're going to want to make sure you leave extra time for the testing and the workflow and the training, because going from 9.5 to 12 is going to be quite a leap. For those of you that are on 10 and 11 and going to 12, I don't think it will be as significant, but anybody from 9.5 is going to be an extra timeline associated with that just because of the navigational changes in the system. I'm recommending that you just provide as much information as possible to your providers and the staff. Just let them know that there are changes coming, and you have some rough timelines of what they look like so that people can plan vacations and such, things like that if you need to, just so that they're prepared as possible. And then lastly, understanding all the stage 2 requirements as thoroughly as possible to make sure that when we do get that system, we know exactly what we need to do. We can incorporate the content changes, the application changes, workflow changes, and get it up and going in the system quickly. Here is a very high-level implementation plan that, depending on your practice size and needs, certainly could put something together quickly like this. And I did stress in here to add adequate time for testing and workflow analysis. Basically, from this perspective, we're looking to do workflow, we're looking to test our forms, provide the implementation training that we need. Go live support is something that you may not want to minimize, especially if you're coming from 9.5 again. And providing that support, even if it's for a half a day or something like that, once you actually upgrade to the system. And I think if you can plan on getting that sort of process in place now before we have the software, it'll just make that go easier when you actually can implement. A testing plan, this is another area that you can do now if you don't already have a testing plan in place. This is another sample that we have where we basically have the module, what the function is, what the item is to test, who's going to test it, develop all of those now while we have a couple of months before the actual software comes into play. So that'll give you some time to line up what you want to test, and who can test, whether it be multiple people within the practice, or if you're a larger organization and you want some of your individual practices to test outside of your own IT department. And certainly this is something that you could distribute to them and prepare them for the testing part of it. And also, don't underestimate, for those clients that are on CPS, the PM and the EMR modules. So make sure you're testing both of those and make sure that your workflows are still working the way that they need to, so that your charges are flowing over and registration's coming over the way it needs to. All of that sort of stuff should be included in your test plan. So let's talk a little bit about customized content. So for those of you that have been following the GE webinars, they certainly talk a lot about the CCC forms. and how the majority of the meaningful use stage 2 criteria are available and built into those CCC forms. I know many of our existing clients do not use CCC forms. They have customized content that they use, and there are no plans to move to the CCC forms. So that means that we need to spend some time getting those forms up to date for stage 2 criteria, and also just in preparation for testing on the upgraded product. So one of the things that I'm just kind of calling out here is that there is the potential impact on testing because we know we have MEL data symbol changes. We know that there are new data symbols for things like medications and immunizations, and those may potentially impact forms that you have in place. So when you're developing any sort of implementation timeline, if you have customized content, I would suggest leaving yourself some extra time to be able to thoroughly test those and make sure everything's working properly. And again, for those of you moving from 9.5 to 12, there are potentially some navigational issues that you will see within the forms. And what I mean by that is the screen sizes are a little bit different when you move from 9.5 to CPS11, for instance. And it causes scroll bars that providers do not like, both horizontally and vertically. So that is an area that you'll want to potentially, again, add more time in because you may need to actually change forms sizes to make them fit into the screen. And again, we can look at our customized content that we have right now, and we can start doing some of the upgrades for meaningful use stage 2, at least planning on what we might want to put into place for that. We may not be able to thoroughly put everything because we know there are changes to the system and data symbol changes, but at least we can begin the process and have an outline of development for when that actually occurs. So just some specific examples that I kind of wanted to talk through. One is the vital signs forms. Anybody that has a customized vital signs form, it probably is in place for most of you that have customized forms already, but I thought it would be a good opportunity to just remind everybody. They did change the requirements in stage 2 that height, weight, blood pressures, BMIs have to be numeric values only. I would assume that if you already had these forms in place that you probably had some sort of mask on your form so that the user could not type in, for instance, 5-2 for a height, which is my real height, by the way. But if you wanted to put that numeric mask in place in Visual Form Editor so that you could eliminate that issue, now is a good time to do that. And that will help you do things like automatically calculate your BMI and use other calculations in the future. So if you haven't done that, it's best practice to do it anyways. It's a good time to take a look at our forms while we have some opportunity waiting for the next release. Your risk factors or intake forms, anything that is capturing smoking status. So they added a couple of different things to us for this year in stage 2. They actually added, I think it's heavy tobacco smoker and light tobacco smoker. So those are 2 things that we can go in and modify in our forms to make sure that they're actually there as options for people to choose from. Anywhere that you have that existing option that was available in stage 1, you can just add the new items for stage 2. That'll be one less thing we have to do when we upgrade. The family history form gets a little tricky. We know that GE is going to have a new form that is in HTML format for family history. At least that has been discussed in several webinars in the past, so I'm assuming that's going to be the case. Many organizations may choose to go ahead and implement that form because it is going to be tied to a new table in the database. If you decide, though, that you want to keep your existing form, as it is today, you're going to need to change the structure on it. Back to Tanya's item where and that's if you're choosing this as a menu item, which I would recommend because most people are capturing this. If you are using a form right now that does not capture family history by the family member, so many of us, for instance, have family history, or we might have family history of colon cancer, mother, father, brother has it, but it's not captured as mother's family history is this. And that's how we kind of have to think about family history now. So we have to capture it discreetly based on the first-degree relatives. And we know that there are going to be some new tables and, as I said, MEL symbols for this in the database. But what we can start doing is talk about what that layout would look like. So if you are deciding that you're going to keep your custom form for whatever reason, you're going to need to think about, okay, I need to flip this now, and we need to address mother's history, father's history, brother's history, children's history, and what the layout would be for the providers, what they would best like to see, and what the workflow might be to accomplish that. And again, these are things that if you have patient portals in place, if you have patient link, other tools that you are using, you want to consider adjusting those as well so that you're capturing this history in the way that it needs to. Outside of the clinical content itself, there are several changes to the application, the setup of the application, and these are areas that I think, as I've kind of looked through this and started understanding what we can do to prepare, there are a couple that stood out to me as ones that we could really focus on, and orders is one of the big ones. We know that in the CPOE measure, we now need to track lab and radiology orders in addition to medication orders. So what we know is that the upgraded product, and I do want to apologize that my webinar keeps referencing CPS12, but this should be for CPS12 or 9.8. The updated product does give us the ability to classify orders. So we can say that a particular order is a lab order or a radiology order, and that's how those are going to be reported out on our meaningful use reports at the end of the day. So what we can do now is really take a look at our orders module and how it is set up right now. So making sure that we go into the categories, for instance, and the things that are in the lab category or multiple lab categories are really lab tests, and that we're really using them. And the same thing with radiology, that they're clearly defined as to what is radiology so that we can classify those easily once we get the upgraded product. Also, if you have not yet implemented orders, why not do it now? We're going to have to do it for stage 2 if you are getting to the stage 2 compliance level. So, it is an opportunity to take between now and when CPS12 or 9.8 is released and actually start implementing orders. Look at your labs and your radiology orders and what you can put into the system and get that process going, because orders are not the easiest thing in the world to implement into the provider workflow, and it will definitely allow for you to have some extra time to get that in place. The other thing is, we are sort of looking at some reports that we might be able to give our clients where we can just sort of export all of your orders categories, to Excel or something like that, and give somebody an option to easily go through and identify, okay, these categories are definitely lab, these are definitely radiology, clean up anything that might need to happen, so that if you needed to pass that over to your lab personnel or your radiology personnel, you could just give them a document that would be an export from Centricity that they'd be able to clean up. So that is something we're working on getting our clients after the first of the year. Okay. This is actually a really cool feature I saw in the most recent webinar with GE, and I wanted to just, again, spend a few moments on this one because I think it's an area that we have been getting a lot of questions on, and I wanted to make sure everybody was aware of this. So they've given us a new option within the user admin of Centricity. And it allows us to identify basically who is an EP, who's a licensed or credential user, and it gives us also the opportunity for each EP to kind of list what their current program is, whether they're Medicare or Medicaid, and what their current reporting stage or year is. So if they're stage 1, year 1, or stage 2, year 1. And you can actually put all that right into the user console of Centricity, which is quite a nice little feature. The bigger one here, which we have been getting a lot of questions on, is the licensed or credentialed staff member who is eligible for the CPOE measure. So this is, entering medications, entering lab orders, radiology orders into the system. And last year, they used the term license. So technically, only a licensed nurse or a registered nurse or a provider was able to put those orders directly into the system. So CMS expanded that this year, and they also outlined credentialed medical assistants as somebody that's able to put those orders into the system. I've heard a lot of discussion about what credentialed means, and I'll just put this plug in here, even if it doesn't necessarily fit. My understanding is that that's a certified medical assistant, and it has to be certified or credentialed by somebody outside of the organization. So you can't just put a stamp on your MA that's worked for you for 20 years and say she's credentialed. And it's important that, when you're setting these users up, that you actually have that information. So if you don't have credentialed MAs that are entering lab orders, radiology orders, you might want to take a look at that now. And there is a section in the new upgrade, I believe, that has a spot to put their licensing information just for your information there. Okay, so that concludes my part of the presentation for this afternoon. I want to just remind everybody we do these webinars about once a month. We have not picked a topic for January yet. We'll be announcing that sometime after the holiday season. So I think at this point in time, I will open this up for questions, and we can spend the next few minutes answering any questions that people have.
Jen, we have one question on the board. On the education and planning, which was the third item on one of your slides, the question is, how much impact is it going from EMR 9.5 to CEMR 9.8? I'm not as well versed in 9.5 to 9.8 as I am 9.5 to the CPS product. But I can tell you that the navigation is slightly different. There are button changes, names that are changed on buttons. For instance, the update button is no longer an update button. There are various navigational changes within the system that are definitely going to require some sort of training for all of your end users. And whether that is a very well-documented handout that you're giving your folks or classroom training will be a decision you can make based on your user, your user population. But the changes are significant enough that you can't just put it in and let it go. The next question is, it's my understanding that GE will be requiring CCC forms even for those who don't use CCC historically. Can we verify this?
Yeah, I have not heard that anywhere. As a matter of fact, even through the various GE webinars that I have sat through recently, they have mentioned your custom clinical content. I have not at all heard that they will be eliminating custom content.
The next question is, does your company know when GE will release CPS12 to begin testing?
I wish. Yeah, I wish I did. No, unfortunately I don't. I do think, based on some of my conversations with various folks within GE, I do think it will be mid to late February, more so than the March timeframe. But, you know, again, that's not something that I would say for certain because it's only just based on conversations I've had with various folks inside GE.
For the specialized registry, does that include an ACO or a group like Better Health of Cleveland? So the specialized registries, along with the ones that I had mentioned, it includes any registry that would provide a process improvement regarding diagnosis or therapy, prevention of conditions that would affect an entire population. I'm not familiar with Better Health of Cleveland. I would need to know more information on what they do. The next question, specialized registries, could you use the state immunization or flu shots, etc.? And that was a good question. I do not believe that you can use immunizations, but I would have to check on that, and I actually have the name of the person that submitted that, so I will jot that down. I do have your email address because you logged in, and I will post that to you as well as to the other folks that have attended the webinar. Hang on a minute, guys. The questions are coming in fast and furious now. Hold on.